Yes, I'd like to introduce myself. I'm new here to the Adelaide PHN. So I'm the current Adelaide PHN COVID lead. So I've been working with Crystal in the last month, taking on a lot of the projects that we've put forward as well. And lovely to meet you, Emily and Melanie. I've communicated via text and email, so, you know, lovely to meet you in person. But I would like to introduce you, Emily and Melanie and Chris Moy, for coming today to present for our primary care update. So I'll hand it over to you, Emily.
Wonderful, thank you. So a very big welcome to everyone this evening joining us for the latest update, COVID update for SA focused on primary care. And a very big thank you again for Adelaide PHN for hosting us this evening. Before we get started though, I'd just like to acknowledge the land in which we're meeting today and the traditional lands here for me, for the Kaurna people, and that we respect their spiritual relationship with their country and pay respects to elders past, present and emerging. So what we're going to do this evening is we've condensed it down to the three of us, and the reason we've condensed it to the three of us, and welcome to Dr. Mel Smith, who's the medical lead of our COVID community team, and also has been a wonderful support over the past 12 months in the GP liaison space, and Dr. Chris Moy, Vice President nationally of the AMA. We've decided to condense down today's talk because there were so many emerging areas that people were keen to really hear about COVID. So we're going to go through a general update around COVID, some of the new pathways, and particularly we'll focus on the changes that have occurred in general practice and primary care for the management of COVID patients in the community, which we have sort of flagged in webinar number 3, but today we'll be talking through what the current landscape is, what has and hasn't changed. We're going to put to bed different myths that have emerged over, you know, what we are and aren't doing in the COVID space, and make sure that it's really clear how you can manage patients in the community or how you can seek care and support through our community COVID response team and through the GP assessment team. And then we're going to hand over to you, Chris, if that's all right, to give us a bit of an update of what's happening nationally and on different pieces of words of wisdom, a bit on e-prescribing. I'm hoping you're going to cover. We haven't really discussed that, but I'm hoping you can, given tomorrow is the day. And then we'll move to Dr. Mel Smith, who's going to go through the oral treatment guidelines and focus as well on the pathways for escalation of care for patients in the community. So thank you. Now, as always, please post questions that you have into the Q&A box. We'll try and respond as we move through. If there's particular questions emerging, we'll also bring them up through our Q&A time. And hopefully this will be a real opportunity for people to ask questions, provide clarity, and we'll be able to care for our patients in the community. So we'll get started, and I'm really thankful that I've got some modelling data that's been given to me through the Royal Adelaide, through Joe Varney, who does a fabulous job there collecting their modelling data. So we'll move through the slides, and hopefully you'll let me know if there's any issues with my slides. So far or not. All right, so I'm going to focus on the community response. And these are the 7 areas I'm going to cover in this presentation. So you're going to be wowed, you'll be sick of my voice by the end of it, and then we'll move to Chris, who will keep us on our toes. So just a little bit about where we are currently with COVID cases, and this is one of my favourite graphics. It's a little bit old, unfortunately, now the data, it's almost a week old, and where we're currently sitting. But it's just very helpful, I think, to sort of paint where we're heading and where we are at the moment. So of course, we talked about our Delta planning back in November. We were sitting at around, we had the breakdown of our pyramid, you might recall, and we were focusing really on that top proportion in the acute space, in our hospital and the hotel, and then patients in the community. Well, we're in a different space now. We are sitting at 99.3% at the moment in the acute, in the community, and then we're sitting at 7% in the acute space currently, and very few numbers in hospital and the hotel. It's a little bit lower than what those numbers were from last week. If we look forward as well around the cases, we've had 2 days in a row now just being over 5,000 active cases, and you probably have all been aware that the modelling data that came out did indicate that we would expect to see some increase in cases over the next couple of weeks, peaking between that 8,000 and 10,000 mark per day, and noting as well the recent relaxation of restrictions that we've seen here in the state. Had a fabulous festival season, fringe season, return to schools, return to universities, lots of different factors altogether. We know that contributing to our case numbers. But of course, these numbers are also reflected interstate, and the pictures that we've seen interstate as well. So some of the new things that really have come up since our webinar number 3 has been the focus on high-risk patients, and this is where we'll come to with the revised community model, which is more focused on high-risk patients. We've had an expansion of the GP assessment team who've been doing a fabulous job. That team has been undertaking record calls, supporting patients in the community and providing incredibly valuable service for escalation particularly, and for high-risk patients in the community, and will continue to do so. We have Health Direct as well now supporting us, and I'll come a little bit to where Health Direct sits in this. We did touch on Health Direct a little bit previously, but where we are now mirroring the other states, utilising Health Direct as that primary entry into the COVID management pathways. And finally, the COVID care centres, where we've had over 900 presentations as of last week through the COVID care centres, and we expect this week would have increased even further. And noting we've got Eleanor down in the south, and we've got Jackie in the centre, who'll be doing a fabulous job as the GP leads for those COVID care centres. So we look at the predictions, and I always like looking at the predictions to see where we're going to be heading in the cases as we move forward. And Tom Dodd, believe it or not, has taken leave and is on leave at the moment, which is the first time he's taken during the whole pandemic. And so Tom is not here to present, so I'm going to present his slides for him. But essentially, he presented last time around varied of concerns, and we can see when we're looking at the graph here now where our BA2 is sitting. So we're sitting at 70% now of cases that we undertake genomics on are sitting at the BA2 variant. Of course, you can just can't even see any Delta at all now on there. And that sort of dropped off. If we look closer at that sort of dropped off around about beginning of February time, where we stopped seeing Delta in the community here in South Australia. But I will say as well, on the sampling of the genomics that is taken, it is focused on patients who are in the hospital setting, acute setting, international travellers coming across, and a small sample in the community. So it really is focused on those people who are in those high-risk settings as well, or high-risk, being admitted into the high-risk settings, I should say, in the acute setting. So that's really pleasing to see, because that's likely where we would pick up Delta if it was circulating in our community. So we know that those case numbers went up yesterday and again over 5,000 today. But in terms of the ICU numbers, I mean, this is really pleasing data to see. I mean, this is very different from the modelling that we had with Delta, much lower numbers sitting in the ICU, and of course, it's sitting well below prediction lines as well. So I think that just goes to show everyone's doing a fabulous job looking after patients in the ward, but also in the community as well. Now, I just thought this was a point I would just touch on with is reinfection. And the reason why reinfection is quite an interesting point to talk about is you may be aware the guidelines recently changed, and they were the national guidelines with CDNA recently changed to being a 12-week interval from when an individual has had COVID to when they're not classified as a close contact if they come exposed to another case. So that's 12 weeks you get now. So I'm still in my 12 weeks. It's been exciting for me. I've got to extend out my time from having COVID in January, but we're in this point now where we do need to really watch and see where the evidence is and look at those reinfections. And we have seen reinfections less than 12 weeks. So I just want to point that out, and that's been proven on genomics, and we've had that here in South Australia. But of course, those are very rare circumstances, and that national position has been taken now for 12 weeks, gone from 4, 8, now 12. If we look though, what that's trending, and this is particularly from the UK from last year, and this has only just come out, as some of you might have been aware of this or following and tracking and seeing what's happening in the UK with the literature. We do know that there is that real risk now around that reinfection, particularly overseas where there's been different variants of concern. So it'll be interesting to see what happens here with BA2 and what the risk is then for further exposure against BA2 versus BA1 or Delta. And we do know that this is going to be a really interesting area that we'll be watching. Now, predictions in terms of hospital rates, and I think this is always just quite interesting to see. So if we look at the current modelling of where we're at, actual numbers are a little bit higher than expected for yesterday's numbers, but have been sitting below where our expected occupancies were, particularly for the hospital, which is really pleasing as well. And our ICU numbers are sitting below, as I just flagged previously. So this is all taken from the RA team, do this excellent modelling based on their ICU team, as I said, with Joe Varney. It's also going on leave. So it's good people are taking some leave now, which is fabulous. But really just wanted to point out here that it is sitting below those numbers. So a big thank you for Joe for sharing that data with us. And then the final graphs, and these are the ones I've shown before as well, have been around where do we see this this modelling going, and what does it mean when we look at that second peak and where those case numbers are. And we can reflect on this looking at border opening. Of course, we had that sudden high spike and we thought it might go up a little bit further. We had those restrictions then come in, which was really, really timely, coming in on the 28th of December. So there's a drop off of cases then coming through, and then we're just going up now, but still tracking on a low prediction line, which is really pleasing. And that, of course, comes back to everyone doing the right thing, getting tested when symptoms present themselves, quarantining and having strict quarantining for close contacts as well. And we did have that change in policy at the end of last week, moving from 14 days down to 7 days for household close contacts. So that's a little bit of the modelling. I think that's probably enough modelling to show. So I'll move on now. Exposure risk for general practice is the other area that we provided some update on as well. And we've had quite a number of inquiries come through to the GP liaison team around what does it mean for general practice now that we have changed the definition up to 4 hours now versus 15 minutes. So general practice has for some time now been following community exposure definitions, and there has been no matrix. People have asked, oh, where's the matrix gone? We ended up removing that matrix a little while ago now. So it is just following the guidelines that we have out for community exposure. So hospital settings different for general practice, community settings, private practice, private specialists in the community. It is following that 4-hour period. But to emphasise as well, and I think this is the comment we always try to put out in our comms as well, is that you still need to be wearing an N95 if you're undertaking an aerosol generating procedure, but a surgical mask otherwise is very much acceptable PPE if you're not looking after someone who is COVID positive or suspected of having COVID. And that's just part of our standard PPE matrix, not the exposure matrix, so just to emphasise that. Now, GPs being notified of non-referred test results. This was the other point I was going to get Tom to talk about, and Mel might touch this a little bit later as Mel sits on the testing groups here within SA Health. But GP referrals can be accepted at drive-through testing sites. And I noted, I think, beginning of the week, there were 3 cases of influenza A reported that I saw came through. So if we think about, we are definitely seeing viruses circulating in the community that are not COVID. So you can refer your patients to one of these drive-through sites. They can take the form with them. You can email the form. They can print it out. They can take it with them to one of these drive-through testing sites, and they will be able to test and undertake a respiratory panel. Now, we don't yet have the multiplex test here up and running and ready with the IT systems. It's almost there, but it's not quite there from an IT point of view. But when we do have that, that will allow for the COVID and influenza paired testing that we know is going to be very important for us as we move forward into those winter months. Now, the other big piece of feedback that we have was sites, including GPs, being CC'd in on results. So they can do that now at all of our testing sites, and we know the private labs have been doing this for some time. So please encourage your patients to ask to add on their GP into their results. Now, if you're not very happy that your patients CC'd you in results, look, I'm sorry, we can't do a lot about that at this point in time, but know this, everyone who tests positive for COVID is getting the same outcome now, and I'll come to that as we work through these slides. So there's not the onus on you particularly to follow up your patients. However, they may actively reach out to you seeking care for COVID, or if you know if they're high risk or immunosuppressed, then you've got that straight away flag coming into your inbox that they will be eligible for treatment and would require that additional care. So it is a bit of work if you don't know about it, particularly if you're high risk patients, but please keeping in mind this is how we're sort of trying to transition now back into this business as usual, but still allowing people to turn up to test sites without a referral form. There is future work underway to support electronic referrals with Citrix, which is, we have in place for blood collections as well that came in 2020, that started with SAPATH. So still a bit of work to try and get that sorted out, but we're hoping in the next few months we'll have a very, very clear pathway for referral for influenza and COVID testing here in South Australia, particularly focused on high-risk groups. Now, move on to vaccines, and please, as I said, post into the Q&A if you've got questions going through it, and we'll get to those as we move through the presentations. I want to just talk about vaccination, and a really big shout out and thank you to all the GPs, pharmacists, everyone who's doing vaccines in the community is absolutely helping us get our numbers up. But our numbers are still looking a little bit sad, and particularly a little bit sad in the children, 5 to 11-year-olds, which is a little bit low, the rates that we would like to be seeing, and particularly the fact that we're still sitting at around 55% of children aged 5 to 11 having had that first dose. So we do need to encourage uptake as much as we can. And I think there's been a bit of discussion around this, how valuable is it vaccinating children? Well, there's been a really good article, we'll put this actually in the chat box, that's just come out through the New England Journal of Medicine, really emphasising the importance of vaccination in reducing that risk of severity of illness. So we will post that in the chat, and that was pleasing to see that that's just come out, that particular article, emphasising the importance of vaccination. The other area I will just mention is long COVID in children as well. Now, we've not really had a lot of discussions about this in kids, but overseas there is certainly quite significant reports of long COVID in children. And so we know that vaccination can be a factor in reducing that risk of long COVID. I know there was an article there was a paper particularly published on adults in this, but it is something to keep in mind when we are talking about vaccination. It's a little bit lower than we would expect, and particularly a little bit lower in our booster doses here in SA, but it's the children we really do want to encourage to take up vaccination. Now, I did just want to talk about the winter booster dose that was announced last week. And this is that dose that's been advised for individuals who are at greater risk of COVID in that more severe risk of severe illness category. So adults aged 65 and over, residents of aged care or disability facilities, and people aged 16 and over who are severely immunocompromised. And this already aligns with that third dose that we had in there already for the COVID vaccine and Aboriginal and Torres Strait Islander people aged 50 years and over. So this is really meant to be a real way to try and reduce down severity of illness over the winter months, but really interesting around the use of concurrently administered influenza vaccines at the same time as having a COVID vaccine. And we know that if you're using an adjuvant vaccine, and the data, and Professor Helen Marshall gave us a really good update on this last week the week before, to our COVID vaccine strategy group around this, and about how important it is thinking about concurrent administration, because if you're giving the adjuvant flu vaccine at the same time as your COVID vaccine, you're increasing the performance of your COVID vaccine. And this is an important point to consider as well as we move forward, and we're getting the stock now in of flu vaccines, and we expect from next week we'll see a greater rollout of flu vaccines across into different spaces. That concurrently pairing the two is actually a really smart move for your older patients to enable them to get that better protection from their COVID vaccine. This is focused, of course, on the over 65s. We do have the new over 60-year-old adjuvant vaccine in pharmacies as well that can be administered, but that's not on the NIP. So just wanted to point that out about the winter booster dose, and it can be given 4 months after someone's had their first booster dose. So we're not expecting really large numbers right now who'll be ready to receive that dose, but coming up, particularly in the winter months, to consider whether it can be concurrently given. We had a meeting today with the Commonwealth to talk about primary care and MBS item numbers, but I've been told it's all shut now. Budget's all been done and dusted. There's no further changes that we'll see in MBS item number rebates for this, but Chris may comment on this a little bit as he moves forward, because the AMA is still meeting, RSGP is still meeting weekly with the Commonwealth around some of these areas. So it is an area that there was a lot of advocacy around vaccination and different changes that may come into effect, particularly around co-payment ability with COVID vaccines. But I'm told there'll be no further change from what's been agreed to in the budget this week. And finally, now we wanted to put this in here, was updated vaccination advice following COVID infection. And this was important because we had provided some advice a little while ago now when there were some initial concerns around PIMS-TS, and that's the paediatric inflammatory multi-system syndrome that we had seen emerging, and we'd had I think about 7 cases in the end we had here in South Australia that at the time that we were referencing, and I believe there may have been a few since then, but this has all been kept in tracking the Women's and Children's now around these case numbers. Been discussion around whether there might have been a relationship between COVID vaccination post someone having had a recent COVID infection, and there was discussion around whether there would be formal guidance to delay vaccination longer than 4 months between the active infection itself and then a COVID dose or a second dose if someone had already had their first dose. We have brought that back now just to be very clear that whilst it can be deferred for up to 4 months, that really it's very safe to be giving. Now we have that information, very safe to be giving after the acute or active infection resolves, and it can be given ideally. The immunology advice would have is 1 to 2 months post-infection, just because that just allows the immune system to reset, thinking like it's a vaccine dose itself if you've had the infection, and then you're giving that actual vaccine then at that 1 to 2 month mark after having had an active infection. So we just have updated our advice a little bit on the website just to be really clear that it can be deferred, but anyone who turns up after their active infection has resolved will still be given the vaccine. They won't be refused being given a vaccine. We'd heard some reports of that occurring. And then just make comment as well about the monoclonal antibody infusion. So sotrovimab, if someone has had an infusion, they do need to wait 90 days before having a COVID vaccine. And the final point it was just around serology. We'd had some questions coming through around serology. Is there any point measuring serology? Now, this is focused on vaccination. No, is the answer. It's not a reliable indicator around the effectiveness of your vaccine-mounted response. And we have been getting reports as well of people requesting COVID serology because they're uncertain if they've had a COVID infection and fatigue. And we've seen as well serology being ordered in a case of issues around pregnancy. But the advice still very much is to not perform it unnecessarily because there are some issues around interpretation. But we know that that still is being undertaken. So we'll just make sure that people do get that advice from the immunology team or call through to the immunology advice registrar at the right if you are looking for specific advice around what to do in those circumstances. Now, all right, I think that's covered through enough around those COVID updates. And as I said, keep posting questions in the Q&A. I must admit, I'm not looking at them while we go through because I can't manage 3 screens at once. But we will come to those as we progress through. This is really where I wanted to spend the time just talking around, and I'm already at 23 minutes, so apologies. Community living with COVID patient care model. And so this has caused a lot of discussion in the community for the last week around how is it happening now? How are patients being managed for COVID? Well, the biggest change that we've had over the last couple of weeks and was operationalised on Monday, just gone, is that we used to have a health assessment that was sent out. So it was an SMS link that had a button that you click and then you fill out a 32-page survey. Some of you may have done that. Some of you may not have done it and given up halfway through. But essentially, it was a survey to fill in around your close contacts, your exposure risk, where you'd been, but also contained a health assessment at the end that went through a series of questions around what your risk factors were and your symptoms. We have stopped that survey. And people said, why did you stop the survey? Well, we weren't actually getting a really good response rate back on the survey. And the people that we were most worried about weren't completing the survey. So we weren't seeing the responses. We don't get them back for our disability and aged care sector. And this week we have noted an increase in aged care, residential aged care facilities being impacted by COVID. We weren't seeing it particularly in our rural and remote patients. We also weren't seeing it in people who weren't reporting in their RAT results or not getting tested. So we had to really rethink how are we going to change this so that we can try and help the community understand how they can seek help if they're unwell or if they've got risk factors themselves, and they get offered then the opportunity to go through the Health Direct call centre. And what we have set up now, and you'll see here where we've got Health Direct, so if someone tests positive, they get redirected to the phone number for Health Direct. And that number enables people to be able to seek advice about what to do, anything related to COVID. In fact, their top queries are not actually clinical assessments, they're general COVID questions about what do I do about close contacts or where to get my RATs. But the other main part of it is they are running the risk assessments now, which follow the national criteria around whether someone is low, medium or high risk, and then can appropriately refer on based on that national evidence task force, which we know had great representation, had a lot of involvement from the RACGP. And so what they're doing now is referring that if someone meets the severe criteria through to 000, if someone meets the high risk criteria through to our COVID response care team, which links in with the GPAT team, our GP assessment team, or GP gypsies. And then the next group it refers to is someone is in the medium risk. There's the opportunity for that person to be referred into their usual GP. And this is the Health Direct linkage system, which will then come through Argus or through HealthLink or however it's referred into your practice. And then, and that's if the person says that they want to be referred onto their GP. I think we had 15 today that I looked through the numbers that went through to GPs here at SA. Or if someone doesn't have a GP, they can be referred to one of the GP respiratory clinics or to one of the GPs that are sitting on the Health Direct GP clinic finder. And finally, if someone can self-manage at home, then they're given that advice for self-management. And the really great thing is all of that information links into our SA Health system, so we can track and see what's happening with people if they are deemed high risk through Health Direct. The final addition that Health Direct brought in last week was now as part of their Symptom Checker link, and that's the link that we send to everyone on their SMS. It actually does a risk assessment around whether they may be eligible for oral treatments, and Mel will go through that a little bit later in tonight's webinar. So that's the biggest change now, is that everyone goes through Health Direct system if they need care and support, and that's dialing the 1-800 National Coronavirus Hotline, which is the Health Direct system, and clicking the Symptom Checker as well to see if they're eligible for oral treatment treatments or what their symptoms mean in terms of what action they should take. And then, of course, it's exactly the same process. If GPs have concerns about a high-risk patient, it's the same call through to our cricket team. It's the same system through to our GPAT team as well from the local hospitals for our pregnancy care, and also for COVIDKids as well is through our high-risk teams. And so, yes, no change to that middle part. It's the front end that's changed so that we can capture as many people as possible and not miss people, because we're very worried that we're missing people. We're getting to people too late in their course of their illness. And Mel will come to that around the timeframes of referral for oral therapies. Probably the final thing I'll mention, which is the final boxes on the side of this page here, which is around referral options for patients. And I wanted to point out here, as a good time to mention, is the PHNs have a support in place through Wellbeing SA with the Metropolitan Referral Unit, that if your patients need face-to-face, so they might need a wound dressing if they're at home who are COVID positive, they might need just some eyes on around, and maybe they need a blood pressure check, and you've got very specific criteria you can give through to the Metropolitan Referral Unit. That's been funded through the PHN, and we can certainly send through the links to do that. It was on the PHN update recently as well. But we're not really seeing that service utilised a lot. So if people are happy to refer, it's another great way that you can get your patients seen eyes on by the nursing team through SA Health. That's probably the main things. I haven't really mentioned about the respiratory clinics on this. So I think I mentioned in the previous webinars that respiratory clinics can see COVID positive patients and just need to book an appointment online. And we're working very closely with the respiratory clinics over the next couple of weeks around what support they can provide for oral therapies. And we'll have more information out soon once we finalise those pathways. That's really it from me. I think last time we were still at 10 days clearance for COVID positive patients. We're now at 7 days. There's no change to the clearance process. They still get an SMS link with a clearance certificate at day 7. And that's it around that. But as I said, please post questions to the Q&A box. I did just put in here very briefly about COVIDKids. So we're hoping to have the pathway set up soon for usual GPs or community-based GPs to refer into COVIDKids. But the options at the moment are still through our cricket team. So calling into the CRCT number, and they can be referred through that way, or through the child and adolescent virtual care service as well, seeing a large number of COVID positive patients. And then they can refer into the COVIDKids if they meet the criteria. So what's next? So this is really a model that we're hoping will keep in while we have the surges, the up and down surges that we expect that we will see. And that's based on the modelling really that we know we're going to get up and down presentations of COVID-19. But what we're doing next is really seeing how can we link this all in with virtual care and support services. We've got the ICC net, which is the iPads where people can monitor themselves virtually at home with support from the through ICC net, which has been in place for some time now in the country, particularly focused on cardiology patients, but now has COVID care. So there's all different pieces that we're working on in this space, but what we're doing is trying to develop a comprehensive virtual model as we move forward into the future. But at the moment, it's still very much health direct, referring on appropriately and encouraging your patients to call that 1-800 health threat number so they can be then referred to the appropriate group, and noting the great support we have from our GP assessment team and our COVID response care team. So there's lots of things we're working on. There's some real changes we need to make around behavioural changes, and this comes back to the oral therapies, which Mel will go through. And in terms of our principles, we've come up with what we're trying to do, and we're really excited now. We have 6 GP liaisons now working in SA Health in the department. Our little unit has grown, which is fabulous, and everyone's working on different things, which is fabulous. And one of those is developing our strategy moving forward as to what are our key priorities. And just to paint where some of our key priorities are at the moment, one of those particularly is around long COVID, another is on aged care response, vulnerable cohorts, and finally on our escalation pathways through general practice to our COVID care centres and other COVID supports. So that's probably it from me. And as I said, we have the old model, we have that now model with Omicron, where everyone got contacted. We've moved now to this new model. And then finally, we're looking at how we can develop a virtual model to support us moving forward that's a little bit more integrated as to what we're doing in other care areas around with SA Health. And that's all from me. So I might hand over now to you, Chris, if that's okay, and give us a bit of an update of where things are up to from your perspective, and then we'll go from there.
No worries. I'm just going to try and do a bit of share screen, if that's all right. So I'll take over if that's possible. Here we go. Desktop. Here we go. slideshow. So I'm just going to deal with a couple of the questions on the chat already, which it's probably worth. Sorry, I'll get rid of this. Excuse me for a sec. Intro, try that again. There's just this question on the chat, which is about these things about the science behind, you know, all the contact, close contact rules and the switch to 12 weeks for positives. I mean, to some degree, not all of this is actually totally science, because the science is you can catch Omicron really quickly. I mean, basically all the rules are being balanced. So every time you make the rules more tight in terms of, you know, making the close contact rules tighter or making the restrictions on how long you have to you have to be, you know, you have to be in quarantine. What you're doing is actually making it less likely that things are going to be spreading, but it makes it hard. What will happen is you get more people out of action in terms of, you know, stuck in quarantine and getting in restrictions or caught in that situation. And that has a cost as well at the moment. Now, as things get more relaxed, then the rules are going to get looser in terms of close contacts and positives, because essentially the point is that if we can see that we can get increasing numbers without increased numbers in hospitals, and that's the major game in town, then those rules can be relaxed. It's not based on science. We can afford to miss some people, essentially. That's the bottom line, but it means we're going to get more cases. So it's just real balancing act for all the people, you know, and SA Health has been excellent in this so far, and using their modelling numbers to sort of predict the number of cases in translation into number of cases in hospital to try and work out what they can do to relax things. And so we've been in pretty good stead in South Australia compared to the other states. And so just understand that it's not purely political, it's not purely scientific, it's about trying to get the right balance of type 1 versus type 2 errors, and getting the balance of number of people stuck in quarantine versus the number of people getting it and getting sick. Now, the thing that's saving us at the moment is not just the booster rate. The booster rate is a bit sick, but we've actually got a pretty high rate of boosters in what we're really lucky at the moment is got quite a high booster rate in the older age groups. I don't think they're all over 80, 85% at the moment, which is actually saving us at the moment, because that's the group that has to be boosted up and up to date as much as possible, because they're certainly the highest risk. So just don't view these things as just political. These are about trying to get the right balance of allowing community to not be stuck in quarantine versus not having too many people getting sick and therefore getting COVID and ending up in hospital. So look, I will just go over the issues. Just the first topic is the winter dose COVID vaccine, just to clarify a few things associated with the PBS and other things like that. So just as this is the provider bulletin that came out, some of you may have seen this earlier. So just reiterating, the winter dose is a 4th dose for those people over 65 years in age, over residents aged care facility or disability disease, and over 50 if you're an Aboriginal or Torres Strait Islander. For those 16 years and older with severe immunocompromise, it's actually going to be a 5th shot. In fact, it actually becomes a 5th shot because most of them will already have had 4 shots. So it'll be a 5th shot for these people. So these are selected populations. Now you'll notice that healthcare workers and other people aren't in there. So the first thing is there's not that much evidence that it's going to make much difference for the other age groups. So the evidence, the risk of giving an extra dose in terms of causing things like original antigenic sin, where you just keep on giving so many vaccines that you just create an antibody to the original strain, is risk enough not to proceed. And you wonder why healthcare workers aren't included in the list for a 4th dose. And essentially the reason why is because there's not much, again, for most of us, as long as we're not in those groups, doesn't appear to be much, the balance of evidence doesn't appear to be great enough to have a 4th shot to make it much difference in terms of severe disease. or reduction in transmission. And also the fact that most of the transmission to healthcare workers at the moment is not occurring in healthcare facilities. It's actually occurring in the community. So in fact, we just become just like everybody else, in fact. So at the moment, the benefit of us getting a fourth shot to try and reduce transmission in healthcare facilities isn't there at the moment. So that's why we're not on the list. Now, so that Emily brought up, can be given from 4 months after the booster dose or 4 months after a COVID vaccine infection. Now, it can be co-administered influenza vaccine. And just to answer a question on the chat, Pfizer and Moderna are preferred, but AstraZeneca can be used with mRNA vaccines if contraindicated or a patient declines vaccination with mRNA vaccine. And in very important key words here, Novavax can be used as a booster if no other vaccine is considered suitable for that individual. That is a very, very wide definition. So, you know, if it means the difference between getting somebody to have it or not, that might be worth getting them over the line with Novavax, even though the evidence isn't that high with it. Now, the important line is after that, payments for the winter dose will remain as the same as for the administration of all other booster doses. That means the $10 extra is included in that. It actually is counted. So we fought very hard for that $10. We weren't sure we were going to get it for this extra dose, but it will be paid. And you can now, importantly, if you look at the provider bulletin, the COVID vaccination and influenza vaccination can be administered at the same time, and you have no obligation to bulk bill the billing for the influenza vaccination, but you should bulk bill the MBS part for the COVID vaccine. So it's changed slightly. So if you end up doing 2 bills, you have to bulk bill the COVID vaccine component, but not the other component for the influenza. So it's just like business as usual. So if you're doing that, that just gives you some clarity about what you need to do. Look, I just wanted to, I'll jump in front of Melanie just to run through where we're at with antiviral treatments. I won't go into too far about the general concern about the fact that because the window is so small with antiviral treatments, that getting the patients to the antiviral treatments is the critical discussion. And I'll probably flesh out some of the concerns with Melanie when Melanie speaks. But can I just say, Jenny Biggins, I'm giving a call out to you on the meeting. She has said that one of the most important things we need to do is get our patients who have positive rats to register their rats which are positive, so they can get in the system, so that they can be contacted, and then we can get them going so that they can be assessed whether they need the antiviral treatment. So please encourage them to do that. And also for patients out there, the problem is the window is so tight. Those 5 to 7 days is so tight that like we shouldn't be, they're going to be recommended to come to see us, but if they get seen at the on a Friday afternoon and they're at day 6, you know, they really shouldn't be waiting for us, and we need to get them into some other system, any other system to get their treatment. Now, just a state of play with the antiviral, sotrovimab, which is obviously the one you're most familiar with, has been the best, but unfortunately with BA2, it doesn't seem to be anywhere near as effective. And you may have heard already that the FDA have removed the emergency use provision for sotrovimab in several states where BA2 is now dominant. And certainly in Australia, it's being looked at again because of the relative ineffectiveness of BA2, and there's increasing evidence for that. The second thing is Paxlovid remains extremely effective, but has the problem of the issue that it has significant interactions and can't be used in significant renal or hepatic failure. And at the moment is not on the PBS, so it has to be got through the same state system that we have now, which Melanie will go through, but just be aware that's the issues with that. Molnupiravir is on the PBS, but unfortunately, in terms of its general, most recent study effectiveness is relatively lower than the other two have been. Now, sotrovimab, theoretically 90% effective until we've had BA2. Paxlovid, about 90% effective, but with all the problems. Molnupiravir, the initial study was about 50%, the second study was about 30%, so we're averaging it at about 35%. Now, from the point of view of the use of these medications, Melanie will talk about the fact that it's the least, it's under the current SA recommendations, it's used if the other two are not suitable or available. Now, molnupiravir is an absolutely reasonable option, but especially, if your patient if it's quite late in the game and your patient is happy to take it and can't be bothered going in and getting something else, or you can't get them in time to do something else, but just understand the recommendations. Now, I suppose from a at the moment, because of the lack of use of antivirals, which, as I said, is the overall biggest concern, it would almost be better if we could get everybody to have molnupiravir rather than not have anything at all. But from an individual patient point of view, I suppose you do need to know the current recommendations, and that you do need to go through that with patients as to what they would accept, essentially, that there are other treatments that are available, and that if I could put it a medico-legal point of view, and the current guidelines indicate that the other two are preferable, but they may not want to do that, and molnupiravir at that stage is absolutely reasonable. It's just a process you need to go through and inform your patients like you would with any other option, any other treatment, and that's what I sort of want to balance this. I know it sounds complicated, but essentially at the moment, sotrovimab and Paxlovid are ahead of molnupiravir on the guidelines. As I said, sotrovimab's got an asterisk, but ultimately you can prescribe molnupiravir if it's, for many of your patients, the only one they'll accept it if they don't want to go into hospital to have an infusion.
Chris, I might just add in there as well. I mean, this is just for awareness. We've got the latest data we've got today was 104 pharmacies across the state are actually stocking molnupiravir from today. So I think we just need to emphasise that whilst they're probably only carrying 1 or 2 doses at some of these sites, there's been a real push to try and get this into community pharmacy as an option for people who can't come in or are not eligible for some of the other options. And we'll come to this with Mel's talk a little bit around some of the access issues and supply issues that we've got at the moment with sotrovimab. So this is really seeing us now thinking about, even though molnupiravir is only giving us that 30% versus 80% effective rate, we do have to be conscious of the fact that we are trying as much as we can in people who are in those lower risk categories, but still meet the criteria to use to consider using molnupiravir, given the ease of access now within community pharmacy, and then for delivery out through the pharmacy as well. I've just been so impressed with how many pharmacists have taken this up, and there's been a real push to try and get stock out so it's quick. So I just want to add that in, Chris. So 104 community pharmacies we had this morning.
Also be aware that a lot of the aged care facilities have supplies of these. So it may be the best option, the most convenient option in an aged care facility. Again, you just need to go through the process and understand what the current thinking is. Evusheld is this AstraZeneca long-acting 2 types of monoclonal antibody, which is theoretically given before people actually, for immunosuppressed individuals before who are at higher risk. Now, I haven't actually seen any of it. I'm not sure it's landed in South Australia yet, but the only this was going to be the great hope out there that this was going to be another thing, but unfortunately there's some new in vitro studies that show that it's not that great against BA2, so we'll see how that plays out in the next little bit. Remdesivir is actually currently, I know it's basically been used in severe COVID, but interestingly, the TGA are currently going through the potential approval process for the use in mild to moderate COVID. So that's something to be watching out for. Look, end of image-based prescribing after today. It's over. So you want to get one off today, maybe maybe go for it. But that's it, unfortunately. Look, we actually did try to push for an extension, but just to explain, the government have had significant problems because of the some safety issues with people using the images several times and getting prescriptions for opiates and things like that on several occasions for the same script and things like that. So it's become a bit of a problem. And so the government on balance have decided to end this, but they have left it open up to 31st of March 2023 for hospital systems. I know this will be somewhat more, it'll be more problematic, but you'll still be able to do electronic prescribing. So image-based prescribing is the idea that we can now, scan it and email it off and write down there to be dispensed by and not have to go through all the palaver. That's what's ending. You can still go down the longer route of faxing it off and sending the script later and all that sort of thing. But in terms of the image-based prescribing and the ease of what we've had so far, that's going. Definitely go to electronic prescribing. The big thing that will be coming will be active script list. So that's the next stage. So at the moment, we've got all these tokens flying around. So active script list is slowly getting bigger. So ask your pharmacies actually whether they do it. So that what happens with that is that all you need to do is you'll see on a lot of your systems, when you send an electronic script out, it'll ask whether you want to go on active script list. But essentially active script list is a list of the scripts in the cloud, which actually collates the number of prescriptions and repeats. And what it means is there's no tokens necessary. The patient can, if they register at the practice, and they give permission for that practice to access the active script list, what can happen then is that pharmacy can access the active script list and dispense a medication without the need of images or tokens or anything, essentially. And so it just makes it easier, and it's going to be particularly much easier for those those patients who can't handle tokens, for example. Now, I know many of you, and being frank, most of us have, with permission, been sending out the tokens directly to the pharmacies. Look, I think essentially, in theory, the electronic prescribing, you're not supposed to do that, but the Department of Health federally, essentially, and I've had a bit of a nod, wink, wink with them, that they're okay for you to do it as long as you essentially get permission from your patient to do that. Because that's a very, very convenient way to email the prescription, the token directly to the patient. Now, directly to the pharmacy, sorry, to bypass this, especially for all our patients who have significant issues with handling tokens. So I hope that made sense. So just be aware, the end of image-based prescribing as we know it, but electronic prescribing definitely on, active script list definitely on. Look, don't blame me for this. The Commonwealth are going to be doing a campaign about going to see your doctor for all your missed tests and missed checkups and things like that over the next few months. So if your patients ask you about that, don't be aware. It was in the budget yesterday, $2 million to come and see you. I'm sure, hopefully you've got lots of appointments to do that, but anyway, they've decided to do that. So if you hear about it, if you hear it from your patients, that's what that's about. Health Pathways South Australia, which I'll keep on going about, has a lot of the information here. It's a one-stop shop for a lot of the information put together for COVID. So it's a good place to look for this information. So thank you. I think you've probably had enough of me. So thanks, Emily.
Thanks, Chris. Always a really, really helpful updates from you, Chris. So thank you. Really appreciate that. And I think this is going to be the perfect now transition now to talking through Mel. So I'll get you to stop your screen, sharing your screen, if that's okay, Chris. Perfect. We'll now move over to Dr. Mel Smith, who is going to give us an update on oral treatments and really just continue on, Chris, on the points that you've just raised around what we need to consider with referring for our patients. And I think you picked up really on that key point around that very early referral on, and we know that it's averaging about 3 days previously getting people onto the system. By the time people go through the system, get generated list, and then we're contacted being high risk. So what we really want to do is people know, as soon as I test positive, I know what to do. I know that I can get treatments. So that's a really key role of the usual GP. So I'm going to hand over now to Mel. Thank you.
Thanks, Emily, and hopefully you can all see my slides.
Sure can. Thank you.
I struggle with these at times. Yeah, so obviously you've just been bombarded with a whole lot of information about pathways and about medications and things, and I just sort of wanted to get down to a little bit of the nitty-gritty around, as a GP on the ground, what do I do? So I guess you've heard a little bit about the Health Direct line, the use of this symptom checker and the National Coronavirus Helpline, which links into Health Direct and provides advice over the phone to patients. And what the big change we've had this week in our system is that rather than SA Health and the GPAT team sort of doing initial outreach assessment of patients that we've assessed as potentially being high risk from our online surveys, we're now trying to get a wider coverage of all of these patients and with the increasing case numbers, and really trying to get the message out there that people can do these things online. They can call the Health Direct line, they can talk to their GP to try and work out whether they might be within the eligible categories for these early interventions. And then they're actually going to be, so once they've self-identified they might be eligible, they'll be directed to contact their usual GP. So for those who don't have a usual GP, Health Direct's pretty good at helping them find a GP out there and can kind of link them in with that. People who are at particularly high risk or have any other kind of symptomatic issues going on, Health Direct will also link them through to the existing COVID response team and to GPAT if necessary. But the whole idea is to get people coming to you and asking, can you refer me for medication if I'm eligible? Because we do know that GPs are the ones who know their patients best and often know a lot better than the patient themselves as to whether they're potentially eligible for this kind of stuff. So it's really important to get GPs and the usual GPs involved. So, oh, my computer's suddenly gone into slow mode. Oh. There we go. I just wanted to show you a bit of a screen grab of the Health Direct COVID-19 symptom checker available online. So you kind of have an idea of what your patients are up for. It goes through a whole lot of different logical pathways, looking at people's current symptomatology, like if they've got symptoms that are obviously really require emergent care, it will direct people to call 000, but it'll also sort of delineate between people with moderate symptoms or mild disease. And it now actually asks about risk factors and vaccination status and immunocompromised status to see whether people are potentially eligible for these medications. And patients can also always call the National Coronavirus Helpline, and that's actually got some really good services, interpreting services and other assistance for people that they can get to through the menuing system on that phone line. So it's quite a good resource that we really need to get people using a little bit more. So the important stuff, and I get lots of questions about this from colleagues, both in my practice and through the GP liaison inbox, around how do we refer people to access, or how do we get these medications to our patients. And I know I've said it before and I'll keep saying it. We have this, we actually have a really comprehensive website now available on the SA Health site that the pharmacy teams have set up. It's a COVID-19 mild illness treatments and referrals page. There's a bit of a screen grab of what it looks like. Generally, if you Google SA Health, mild illness or COVID infusions, you'll get to this page. And that actually is really good. It runs through detail about all the medications themselves, what the eligibility criteria are. It has the links to do online referrals, and it's really the key place to get your information around current guidelines within South Australia to access these medications. And in particular, we're looking at eligibility for Paxlovid and Sotrovimab, which are both national medical stockpile medications, and Lagevrio or Molnupiravir, which is the medication now available on PBS Streamlined Authority. The key point is that, as Chris and Emily have pointed out, referral is really time critical because treatment with these medications really needs to commence within 5 days of symptom onset. In South Australia, we actually have a little bit of leeway and we will start Sotrovimab within 7 days of symptom onset, but for the oral antivirals, it really needs to be within 5 days. So the faster we can identify candidates and get them through the system, get the medication to them, the better. They do make a really big difference to outcomes in these patients. So this is just a bit more of that website, just an indication of all the guidelines we have available for you to use. And I'm not going to go into them ad nauseum because they're super complex and you'll probably fall asleep if I try to work through all of the minutiae of eligibility. But there's actually some really useful flow charts and things on there and really detailed information, as well as patient information sheets and really simple prescriber information sheets on these medications. So I really do urge you to go and check out that website and all the resources linked off it. The bottom line is really that to be eligible for any of these treatments, patients must be confirmed as being COVID-19 positive, so with a PCR or a RAT test. They must have mild disease severity, so that means very mild symptoms or no symptoms at all, and it has to be within that first 5 days. They also need to not have an oxygen requirement. So we're really looking at that category of patients who are in the mild disease category as opposed to moderate or severe and potentially requiring hospitalisation. They also need to be in one of two main categories. If they are unvaccinated or not up to date with their COVID vaccinations, and that means if they're overdue for a booster, so it's been more than 3 months since their second dose and they haven't yet had a booster, they would be classified as not up to date with their vaccines. And in that situation, so if they're unvaccinated, partially vaccinated, and also have some of the risk factors for developing severe disease, so things like an underlying lung disease, significant obesity, age factors, all of those kind of things play into that list of sort of things that will qualify them for these medications. Alternatively, irrespective of what their vaccination status, if patients are immunosuppressed, and there is quite an extensive and detailed list of what qualifies as being immunosuppressed in terms of what medications people have to be on and what underlying conditions they might have to cause that immunosuppression, if they meet that criteria, our expectation is that even if they have been vaccinated, they're probably still not mounting an appropriate immune response. So we still want to get medications into those patients particularly. So that's sort of the basic outline, and you can definitely go to that SA Health website and see the details of what the risk factor listings are and what immunosuppression really means. Then the question comes, well, which drug is most appropriate for my patient? And certainly up until the last month or so, we had been using sotrovimab, the monoclonal antibody infusion, extensively, which has really good effectiveness, up there, sort of 80–90% effective at keeping people out of hospital and keeping them alive in these vulnerable cohorts. Unfortunately, we're starting to see some contraction in the supply for sotrovimab. So it's probably going to become more limited, the access to that, over the coming weeks. We're also seeing that there is some concern that it's perhaps not as effective against the BA2 Omicron variant. And for some people, it's just really not a great drug to use because of the logistics of getting an IV infusion into them. And there's quite a few people who just don't want to have an IV infusion of a strange drug too. So what we're actually moving towards now is that where possible, Paxlovid is probably the preferred medication to use. It has really good effectiveness. It's a 5-day course of tablets, so for some people that's much more palatable than having an intravenous infusion. However, as previously mentioned, it has a significant number of drug interactions, and it does depend a little bit on renal function, the dosing, and it's not approved in pregnancy. So there's a whole lot of complicating factors there. Sometimes current medications can be ceased while people are taking Paxlovid. We then have to make sure that they are restarted appropriately after that course is finished. And it's quite a tricky process, particularly when the patients we're trying to get these medications into are often the ones that have the most complicated underlying medical and medication histories to be working with. And then, of course, there is Lagevrio or molnupiravir, which has a lower effectiveness, far less interactions, but does have some issues around not being approved in pregnancy, and there is some requirement to use contraception for extended periods after use, particularly in males. So there are 3 main drugs that we're working with, and that's probably the order in which they are preferred currently. But, you know, beyond just what's palatable for patients and what might be the most effective, there's also many questions about what's actually accessible in a timely manner. So there's a whole lot of different things that come into this decision making. The first thing to think about if you're as a GP thinking about getting this medication into your patient is that if you can quickly assess that your patient is clearly not willing or able to receive sotrovimab or Paxlovid, you can prescribe Lagevrio if they meet the criteria for that one. And you can do that on a PBS streamlined authority script. And as Emily mentioned, we now are seeing some extensive stocking, certainly across the metro area in chemists with that. And hopefully we're expanding that into regional areas as well. So there have over the last couple of weeks been some issues around pharmacies not wanting to stock large amounts because it is quite an expensive medication to have sitting around, but there's definitely been a big push to change that. So it's there, it's available, and if it's the right drug for your patient, the quickest way for them to get it is for you to prescribe it straight away. If they're perhaps suitable more so for sotrovimab or Paxlovid, you can use the online referral form through the SA Health Mild Illness website to actually do a referral to access the National Medical Stockpile medications, sotrovimab or Paxlovid. And if you go to that website, there's a section on it that you can see here called Refer Your Patient, and it has a link to the online form, which looks like this. And goes through, it's quite an extensive form. So I recommend you do it while you're on the phone to your patient, include that as part of your consult time, if at all possible, rather than leaving it to the end of the day. So, and the important thing about that is that there are a lot of questions. You need quite detailed medication history. You need things like a recent EGFR if it's available for patients who are maybe being considered for Paxlovid. And you really need to make sure you've got the correct contact details for the patient is probably one of the key important criteria here. Because if we don't have a phone number for the patient, it makes it very difficult to connect them in with the medications. So once you have filled out the referral form, what happens next? Well, we have an amazing team of Dardis pharmacists, and hopefully many of you are already familiar with the great work that Dardis do in GP education. But we've got some amazingly dedicated people working in the background processing these referrals and making sure that they meet appropriate criteria to be approved as for use under the guidance that works around the NMS medications. They're currently getting about 120 referrals a day, which is a lot of work for them to work through. So you may find that it takes a couple of days for that process to move through, because once they're approved, and that may require some back and forth with infectious diseases or perhaps to the original referrer to clarify some aspects of it. Once they're approved, they're then for sotrovimab and Paxlovid at the moment, it's being operationalised through COVID care centres and some of the regional COVID accepting centres to actually get infusions into patients and to get them connected into a Paxlovid prescription and supply through the hospitals. We're hoping to broaden that out further into the community and make that medication more accessible outside of large hospital centres, but we're working on that rapidly over coming days to try and make that happen so that we can push access more into the community where patients are, rather than having to bring people to fancy hospitals. So we do get a lot of inquiries, and Dardis, I know, get a lot of inquiries, and the COVID care centres do get a lot of inquiries from doctors who've referred patients for these medications saying, well, what's happened to this referral? My patient hasn't heard anything. It's been a couple of days. If you are concerned about the progress of a referral, please email this email address, which should have a .au on the end of it. So it's health.covid.info@sa.gov.au, and our GP liaison team can access that, and I can actually have a look into the back end of the referral system and make sure that referrals have gone through and what stage they're at in the process, so we can see whether someone's has actually ended up declining having the medication, or if they've not been approved for some reason, or if they're just waiting to be consented. So the next big question we get is, okay, so I've got my first COVID positive patient and they've booked a telehealth consult with me. What do I do? So in my practice, we generally have a couple of COVID phone calls we make on a daily basis. So we'll have patients who've just tested positive book in. So I had a couple today, and I tend to sort of have all the guidelines pulled up on my screen while I'm talking to them and just checking off that I'm going through all the right things I need to check on. I'm also working on an autofill that I'm happy to share. And I'm sure that the GPAT doctors have some good autofills they can use in terms of creating checklists for what to think about when you're talking to your COVID positive patient. But my favourite resource out there is really the National COVID-19 Clinical Evidence Task Force website, which hopefully you're all very familiar with, which is a fantastic resource and really kind of provides that underpinning for all the different guidance across Australia and all the different jurisdictions. So My favourite part of that in particular is their clinical flowchart section. So they have some great flowcharts that help you assess severity of disease in patients, where they should be cared for, whether they should perhaps go and have a face-to-face assessment, whether they need to go straight to an emergency department, or whether you can keep them at home and just sort of do some supportive care for them. They also have a great summary in flowchart form of the different medications and when they should be considered, at what stage of disease, and who might be eligible for those things. And they have this awesome risk assessment tool, which is really helpful for you to sort of think about whenever you have a patient from your practice who has tested positive. And if you are starting to see some of those positive results come through into your inbox from people who've attended mass vaccination sites, this can be really helpful for you to think about, oh, I've seen this result in my inbox. Maybe this is someone who's going to need some medications. Maybe I should organise for them to have a telehealth consult today rather than wait for them to call in to me. So there's also a couple more resources that I really like, apart from the SA Health site. There's also, of course, Health Pathways, and I know that's been mentioned in the chat as well. That's a really comprehensive resource. There's a little screenshot of their COVID section on caring for COVID-19 positive patients in the community. Lots of great links in there. It's continually kept up to date and really does provide a good clearinghouse of information and links to different guidelines. So highly recommend that. And of course, RACGP also has some really good guidelines available on their website. So what if you're working with your patient via telehealth and thinking, oh, I think they need a little bit more than what I can offer them over the phone in my 15-minute appointment today, or I'm not really sure what to do next. You can certainly send any non-urgent queries through to our email address, the health.covid.info email address. Obviously, you can't be sending through questions saying, I've got a patient who's having trouble breathing at home, what do I do? Because we're not necessarily going to get back to you in time. But if you've got sort of general queries or something that, can wait a day or two, please send them through to that email address. You can also actually still escalate care for your patient through the COVID response care team. So that has previously had a 1-800 number that was publicised through to the general public. That number is still operational for GPs to call in and refer patients through and discuss with our nursing team, and potentially also contact our GP assessment team doctors. So the GPAT team generally has really experienced doctors who've been working with COVID for the last couple of years and really are probably the most experienced people in state, if not the country, in terms of managing patients in the community with COVID, particularly via telehealth. We generally have someone available during the day, certainly on weekdays and sometimes on weekends, and we can all our CRCT nursing team can put you in touch with them if you need some advice about how do you assess or manage a patient. They're just such an incredible font of knowledge. I highly recommend getting in touch through that mechanism. And so we're certainly seeing referrals into CRCT, both from clinicians in the community, so GPs or other specialists, or even hospitals who are looking after patients who can perhaps be discharged, and Health Direct are also referring patients into there. So if patients call into the Health Direct phone line through the National Coronavirus Helpline and they're assessed as being quite high risk, they will be referred through to the COVID response care team still. The other huge resource we have are the GP-led respiratory clinics across SA. So we've got 3 clinics in Metro Adelaide who are seeing COVID positive patients face-to-face, and I think we have about 11 sites across rural SA who have been previously been sort of seeing suspected COVID patients, but will now also see COVID positive patients. So don't forget that resource as well. For maternity patients, I know we did a bit of messaging in our last update around some changes to the maternity pathway. So if you have a pregnant patient with COVID, much of what they'll experience may have nothing to do with their pregnancy, particularly in early pregnancy, there's probably not a lot different you have to do. There are a few little things you need to think about in pregnancy, and that's where the National Clinical Evidence guidelines can be really helpful, thinking about VTE prophylaxis in women, pregnant women with COVID. But if you do have concerns around obstetric issues or they're getting severe disease, you can still work in Metro Adelaide with their originally booked hospital in the public system. And Flinders is still providing some specialised sort of escalation pathways, certainly to regional areas and to the private sector and to any other maternity hospital that has pregnant patients with severe COVID. We also have the COVIDKids service at the Women's and Children's Hospital, and as Emily mentioned, we're working towards direct general practitioner referrals into COVIDKids, but at the moment it's really through the CRCT and GPAT is the best way. So if you've got a patient who you think could benefit from COVIDKids input, it's best to refer to CRCT, and then we can push them through to COVIDKids if need be. It's really important to understand that COVIDKids is not just for every child who has COVID, it's really only for those who have significant disease or some complexity around their underlying medical needs or their social needs that really puts them into their category for their care, really. If you have patients who need a face-to-face review, the main, and you're not able to do that yourself, and I know that many practices just do not have the infrastructure to see COVID-positive patients face-to-face safely, you can refer your patients through the GP-led respiratory clinics across SA. You can also do direct referrals now into 2 of the COVID care centres, so the one at Flinders and the one at the Royal Adelaide Hospital. They will both take direct GP referrals, and I've got some contact details up here for Flinders. Both of these will only see adult patients at this stage. I know Flinders is hoping to expand to be able to see paediatric COVID positive patients in the near future, but not quite yet. And they have phone numbers that you can call as a GP. They have slightly different opening times. But the most important thing to think about is that both of these services, both Salin and the Carlin Centre at the Royal Adelaide Hospital, are referral-based services only. So patients can't just turn up themselves to the COVID care centre. They can turn up if they have a booked appointment to see the COVID care centre doctors, or they can go if they've been referred by you, having had a conversation with the clinicians at the COVID care centre. Their capacity varies quite considerably through the day, and they really need to know who's coming. They have quite limited space to put people. So that's kind of most of the things that I wanted to talk about tonight, but I'm happy to answer any questions that might have come through on the chat, Emily.
Thanks, Mel. No, I mean, certainly there is a real need for some cheat sheets in this place, Mel, because we know this is really quite confusing about where things are heading, and there have been some cheat sheets drafted on this. We just need to get them sort of finalised, and the reason why we haven't quite got them finalised yet is because of the fact that there's some changes with the sotrovimab criteria, and as Mel flagged, that there is some access concerns coming up, so we expect there'll be a tightening of the criteria for who is eligible for sotrovimab and a more focus on Paxlovid, and we're really, really hopeful that in the next week we'll have it set up so that we can have community pharmacy or a community link out to be able to prescribe out Paxlovid in a very set, streamlined way. So, for instance, New South Wales is running the system that you can, through GP prescribing, through a QR mechanism, it goes direct into the public hospital system through their LHDs, and then they're couriered out to the person at home. So we're exploring all options so that we can try and reduce down the volume into the COVID care centres. But what we do know is that we did a really big campaign over the weekend, Monday, Tuesday, to encourage oral therapy uptake, and we had so much interest, and in fact it was people from, and we had comments made around, oh, but this is going to delay people accessing treatment, they're not contacting us till day 5, they're right on the cut-off time. But in fact what we know was it was people who hadn't been identified early on who have then realised, oh my gosh, I'm eligible for this, didn't do the survey, so we hadn't contacted them, and now are being eligible for treatment. So it's just quite interesting now going through some of our data and realising how important it is that we do run really strong public communications here, and we know this is a really big a really big role is going to be GP education of patients that, you know, oh, a bit around this COVID planning, you know, what do I do if I test positive COVID? Well, you're at risk. These are the options that we know are for you. And in fact, we know, Mel, that people are coming in, are requesting scripts pre-COVID just to be sure that they had their stash of molnupiravir ready. But of course, that's not a criteria. So we do know that there are different avenues that people can consider. I thought I would just share my screen, and I think we've still got a little bit of time. I can't remember if we were an hour or an hour and a half for this webinar, but anyway, we'll keep going just a little bit more. Someone did make a nice comment in the chat that we could keep going if we went over time. But I just wanted to share my screen on this page, and I'm hoping you can see this now. Did it come up? Can you see that colourful chart? So we'll try, what we'll try and do is try and get some of this a little bit clearer out. But I mean, just things like this are just quite helpful, I think, knowing around the dosing, the doses, you know, what are the days that it's given for, how many days do you give it for? Oh, it's 5 days, you know, it's 3 days. You know, this is the regime. The other thing we'll get to as well will be remdesivir as well, which we haven't really provided a lot of information out, but is being used routinely for acute patients at the moment in the hospital setting. But looking at that more so around how can that be administered in the COVID care centre type space. So there's lots of different things. So these are the sort of charts we are working on and pulling together, and we're grateful for all the work that's been done at the GP team here at the department. But we're waiting on some final information. So hopefully we'll have something out maybe tomorrow, Mel. You never know. We might get something out tomorrow if we don't get caught up with other things. So we'll stop sharing there. But just wanted everyone to know that we are conscious this is quite confusing. We acknowledge that. So we will try and send out some more info as well. And we'll have the slides as well going up on the website from tonight, just so we're really clear. I don't know if tonight, maybe tomorrow, but just so we're really clear on the pathways of the new referral system. So there's been a lot of questions come through. And in fact, there's been quite a number of questions about sensitivity of rats. So I think that's probably an area we might need to dig out some more information and get some more expert advice from our microbiology and from the team at SA Pathology. They did a bit of work around rat testing, and certainly we've been going to the saliva testing and focusing on nasal, really it's on the Roche tests and also the Abbott test that we've been promoting as much as possible because they had that high level of sensitivity. But it is something we can certainly look at. I don't know, Chris and Mel, if you want to make any comment about rat sensitivity?
The previous thing was it was around about 80% compared to a PCR because it misses at the beginning and the end. Basically, it gets it in the peak. So it's quite good at actually seeing whether you're infectious for the next few days or hours. But if it's too early and a bit at the end of as the antigen level drops at the end, then it's less likely, less infectious. But so it's more useful during the infectious phase. Theoretically, it's got only a very small false. So it's got a 20%, about 20% false negative rate. Maybe it's always been said about a 1% false positive rate, although we're seeing a lot more as time goes on. And I hear anecdotal stories about false positive, but that's probably because of the number of rats that have been done and the stories that you hear. The other issue is whether Omicron is missed a bit more by the rats. And there's less conclusive evidence about that generally. But generally, it's the way I think of it, rats are good at picking up, particularly when the infectious phase is, and that's why we're using it in healthcare facilities, for example, to do it before people go to work, for example. Could I just make a comment? I'm just reading the chat, and I suppose there's this overwhelming thing that a lot of the burden is going to shift to us as GPs, and I get that, and to some degree it's a little bit of, it's a bit of it's confusing and it's potentially overwhelming, and it's also everything seems to be shifting through to us as time goes on. The bottom line, and I noticed some of the chat there about the system maybe missing patients more because it's being, a lot of it's has to be done front end in terms of identification and patients then coming to see us. The bottom line is that the previous system was not working after a while because there's just too many cases. So the system, in terms of relying on SA health systems to chase down patients, just wasn't working, and too many patients weren't getting the treatment because it was just taking too long. So that's why, unfortunately, it has to actually shift to us. So I do understand it's a burden. It's not financially that rewarding, and it's a hassle. And certainly the faster we can get cheat sheets, the better. That'd be great. But the reality is it will shift to us, and that's just part of living with COVID. The other thing is that the part of the reason why we don't have really nice, clean guidelines, particularly coming from the Commonwealth, because all the states are doing it differently. And because they've been at different stages of the pandemic and having different numbers. So New South Wales, we went through hell early on, essentially got into trouble so early that they went to complete hell early on, and essentially nobody was getting treatment there for a while, as some of us in this room know, and then they slowly had to sort of streamline it because they realized the state system couldn't go that way. South Australia, because we've had less numbers, have been able to hold that state system for longer because our numbers haven't been so bad. But now we're reaching the same world now with BA2, where there are so many cases that really the burden for identification and referral does shift to us. And so again, it's not, I'm just trying to explain what the layout is. It's not a matter of the system failing. It's the fact that things keep on changing and things are not harmonized across the country, and that we're getting more cases and the burden will fall on us. And that's the plain old reality.
Yeah, no, thanks, Chris. And I agree. It is really quite confusing where we are in different spaces. One of the really good things about Health Direct is we are mirroring the same system in Queensland, and Victoria is also moving to this, where all patients funnel through this sort of system. And in some ways, we need to. I mean, we've already started getting influenza A cases this week. We do have to think about how do we now move into this. It's horrible talking about this as business as usual, because there's nothing business as usual about this. But it's around how do we try and educate the community and move them away from this incredible fear around COVID, to try and encourage them that, you know, there's things you can do to be COVID prepared. You know, knowing what your checklist is of what you need to do, that you go and get treatment, you know how to do it with your GP, you discuss through your plan, you got your food all sorted, you got your friends there who can come and provide support and drop off things to you. I mean, Victoria has done a really good job with this. They've been running these checklists. They've got a very, very strong social media campaign as well, that's particularly focused on cold communities as well. So I think there's a lot of opportunity for us to do more, and we're really keen just to make sure that we do provide opportunities for people to ask questions, escalate, and particularly for GPs to know that we have expanded our GP team here in the department specifically so that we can help and provide education out, and we can make sure we've got the emails covered. We've got a roster now for monitoring our emails so we don't fall so far behind, Mel. We're making sure that we've got, you know, key areas that we're all working on, and particularly aged care is going to become a really big area for us to focus on as we move forward into winter months, influenza risk, and then we know as well around these escalation pathways with the COVID care centres. So I must say we've been working very closely with the PHN. It's great. We're at a PHN webinar tonight around how can we get further support from the GP respiratory clinics to be able to see patients face to face. I must say the GPRCs have been really, really open and accommodating as to how we can try and increase capacity. And when we met with the Ingle Farm team on earlier in the week, there was all these appointments on Saturday which weren't used up. So there is definitely capacity in the system, and we know that there is ability to increase capacity if there's a drive for it. So we want to try and see what we can do around increasing access to treatments into the I saw someone said that we're stealing GPs from the community. Come in the chat, in the questions there. We're stealing fabulous GP liaisons in this team. But we do need to make sure that we've got support in place, because it's just not sustainable, the COVID care centres currently. And I think there was a comment about Narlan as well, you know, what's happening in the north. They've been running an infusion service. It was 6 days a week last week. It wasn't operating on Sunday, but on Saturday they've been, you know, moving through quite a high volume of infusions there at that site. But there's only 2 days a week that currently at face-to-face assessments. So how can we get more opportunities for people to be assessed face-to-face? As I mentioned, there's the PHN opportunity as well through the Metropolitan Referral Unit. If you click on the PHN website, the link's there, so you can refer your patient in if they've got a particular service need in the home, so they don't need to come in somewhere. And then again, thinking as well, if we've got ICCNet, there's virtual monitoring, there's always options for your patients. We're just going to make sure that you've got the understanding of how to refer it. And as I said, please email through to us if you're not quite sure about something. It's much easier just to send us an email, and then we can get to it as soon as we can, so that we're just trying to provide that advice of what to do, so you don't spend so much time thinking, oh my gosh, I can't navigate this. That we can help you with that. And particularly if you're like, where do I go to a pharmacy to find, you know, I mean, we can certainly then send through some of the lists of where we're up to with that. So lots of things. The final thing I will just mention is just coming through, there's a few things that we're always going to get questions around mask usage. I think we all know the value of masks. We're all pretty intelligent individuals here, that we know that masks do make a real difference with respiratory aerosol transmission. We know this has been really quite difficult around access to PPE, but we know that that's improved now, and thanks as well to the PHN and the Commonwealth have committed as well to further funding and distribution for PPE as we move forward and as part of the next budget. Although we'll see what happens with that. In the other areas we've had as well posts that have been around, there's been some questions about high risk settings. So just to emphasise again, general practice is not a high risk, is not classified as a high risk setting under the direction. It is private and public hospitals only, and that's part of the public activities direction. So there is no restriction on people being able to go back into the work in that high risk space. So that's after someone has been cleared as a case, or if they're a household close contact, they can go back to work. They don't need to wear a mask, but you should all be, I guess, all be wearing masks anyway within general practice settings. The other area that is actively being reviewed at the moment is around returning to work as a close contact, and we are hoping to get some guidance out within the next week on that. Again, that we know that there is so much pressure at the moment to deliver services within primary care, that to see how we can get people back to work with a daily RAT test and with PPE provision. So we're hoping to get that sorted out. Again, I know that's been a topic that's come through in different channels. So that's probably all from our end. But of course, Mel, let's go around the room. Mel, we'll come to you and then we'll come to Chris. Just thinking,
at risk of being accused of stealing GPs from the community, I did want to put the word out that the Metro COVID care centres, both in Northern Adelaide, Central Adelaide and at Flinders, are looking for more GPs to come work with them. They're looking for people to sort of do 1 or 2 shifts a week. And really, it's a really good opportunity to build your confidence in working with COVID positive patients. So if anyone is interested, please get in touch with me and I can forward you onto the appropriate team. But they wanted me to put the word out that they are recruiting, but they want real GPs who are still working in the community as well.
That's a dig at me from Mel.
Oh, no.
She says Mel brings all these new GPs bring credibility to our unit here, because I spend all my time here and not seeing patients. All right, I think we'll probably leave it at that. Thanks, Mel. We'll come to Chris. Chris, any final points from your end?
I was just going to answer that last question. When the directions go, there will be the removal of mandatory masks. I mean, there won't be a way of actually making them mandatory at that stage. Certainly they'll be encouraged. And certainly from the Chief Public Health Officer, Nicola, will be able to write certain standards, but there'll be no official penalties for this at some stage. So when the directions go, in fact, the mandatory mask situation will go, and that's looking like it's possibly coming up in the not too distant future, but hopefully we'll have got control of numbers and the control of hospital at that stage. Look, bottom line is, I'll just reiterate again, we are just transitioning into this phase where, we are literally going to have to live with COVID, because a lot of the structures like the mandatory directions and those things are going to disappear. And literally it will fall back onto us a lot more at that point, because we won't have these structures. And certainly it does seem frustrating and a burden at this point in time, but it's a factor of the numbers and where we're heading as far as management of COVID. And it will become a much more normalised part of our work as time goes on. And that's just the cold, hard reality of where we are in terms of the whole pandemic, unless we get a new nasty variant, in which case suddenly we might have new directions again. But anyway, we'll forget about that.
Yeah, it is really around that change in the habits in the community. So it'll be very interesting watching this space, but no doubt all of us will still be wearing our masks in particular settings. Okay, we'll leave it there then this evening. And I want to say a very big thank you to Brendan and Crystal from Adelaide PHN again for their support. And I must say both Country SAPH and Adelaide PHN have been incredibly supportive with us rolling out this new pathway, particularly focused on health threat and helping us with the design of that. And also a big thank you as well to the Primary Care Task Force that was reset up about a month ago now, that we've been meeting to help design this new pathway. So really, really great to have collaboration, particularly from our rural GPs. And I think in many ways we've now put more services out in the regions than what we have in the metro, particularly now that we have more COVID care capacity out in the regions. And we've also got the great ICC Net solutions, which are the tablets, as I mentioned, that are available for GPs to refer their patients through to, focus in the regions. But I'm hoping we can get that more into the metro space as well. Now, I think that's probably covered. I think there were a few questions that were posted into the chat box, so apologies if we missed some of those as we went through. But really, I think hopefully this has been an informative webinar. We'll continue to get info out, email through to Mel and the team, and we'll get onto your responses and help you navigate this complex system. So thanks everyone, and thank you again to Adelaide PHN, Brendan and Crystal.
Thanks everyone. Have a good night.